Welcome to the Psychology Undergrad. Grab a seat.
Yeah, pull up a chair. We've got a lot of notes to get through today.
We really do. So, okay, I want you to imagine something for a second. Imagine you're sitting down for dinner, right? But before you can swallow even a single bite of your food, your brain absolutely demands that you chew it exactly 300 times.
Wow, 300.
Exactly 300. Not 299. 300. Because, like, if you don't do it, your mind insists that the food is lethally contaminated and something terrible is going to happen to you.
Right, which sounds exhausting.
It is. It takes you like 3 or 4 hours just to finish a small meal.
And, the true tragedy of that scenario is that you likely know it's irrational. Like, logically, the food is fine, but the psychological urge is so overpowering and the anxiety is just so blinding that you chew anyway just to survive the distress of it all.
Yeah, that is an actual documented reality for a lot of people.
Mm-hmm.
And I feel like it perfectly frames what we are wading into today. It's just the two of us, and you, the third student in the room.
The best study group.
Obviously. So we are sharing our notes and doing a deep dive into our textbook's chapter on obsessive-compulsive and related disorders, or OCRDs for short.
Right, chapter 6.
Yeah. And our mission today is to figure out the exact mechanisms driving these behaviors and, to equip you with some relatable mental frameworks so these really complex clinical definitions actually stick in your brain for the exam.
Which is super important. And I think we really need to set the stage by looking at how our understanding of these conditions has evolved recently. Because if you look at older diagnostic manuals, obsessive-compulsive disorder, or OCD, was categorized simply as an anxiety disorder.
Which makes sense on the surface, right?
Right, exactly. But recently, the clinical world recognized this massive shift. They actually pulled OCD out of the anxiety category entirely and built a brand new group around it. Because the unifying factor here isn't just the presence of anxiety. The real engine driving these conditions is the presence of repetitive thoughts and repetitive behaviors.
Right. It's the brain getting caught in this endless loop. So to really grasp this whole new category, we have to start with the anchor disorder, right? The big one that gives the category its name, which is obsessive-compulsive disorder.
Yeah, let's break that down.
Okay, so let's look at those two words because there are distinct gears in the machine here. So obsessions are the intrusive, unbidden thoughts or images or urges that just flood the mind. You do not want them, but they just barge in anyway.
Yeah, totally uninvited.
Exactly. And then compulsions are the repetitive physical acts or mental rituals that a person feels completely driven to perform.
Right. And the relationship between those two things is entirely reactionary. The compulsion is performed in this desperate attempt to reduce the severe suffocating distress that the obsession is causing.
And we are not talking about, like, fleeting worries here. We aren't talking about double-checking if you lock the front door once before you leave for work.
No, not at all.
We're talking about cases like Bernice. That's the woman from the textbook we mentioned at the start who had to chew her food 300 times. Her OCD was actually triggered shortly after her father died of pneumonia.
Oh, right, the contamination fear.
Yeah, she developed this absolutely crippling fear of germs and contamination. It was so severe that she spent 3 to 4 hours every single morning just washing herself. Like she would literally scrape off the outside layer of a fresh bar of soap because her brain convinced her the soap itself was contaminated.
Which is just heartbreaking. It completely consumed her existence. And that is the compulsion desperately trying to manage the obsession. But it's also important to note from our notes that it doesn't always look like contamination, and it can affect people who are otherwise highly functional.
Yeah, that's a really good point. Like, the book mentions soccer superstar David Beckham. He's been very open about his OCD, specifically his compulsion to count and recount the sodas in his refrigerator.
Right, making sure they're perfectly symmetrical and even.
Exactly.
Yeah.
Or the actress Lena Dunham, who's battled OCD since she was like 9 years old, and she deals with severe counting compulsions too.
Yeah, and what's honestly fascinating here is how these obsessions so deeply intersect with a person's morality, like their religion and their core values. The textbook points out that obsessional themes usually have incredible personal relevance.
Wait, meaning what exactly?
Meaning, like, people who pride themselves on being deeply altruistic, gentle, and kind are actually the ones most likely to be tortured by aggressive, intrusive thoughts, like a sudden, unwanted urge to push someone into traffic.
Oh, wow. Yeah, I noticed that connection to religion in the reading, too. You see people with very strict, devout religious morals experiencing these highly taboo, unwanted thoughts, Like there are cases of people having constant, intrusive sexual images of Jesus on the cross. And
Exact.
you can just imagine the intense, crushing guilt that causes someone who has devoted their whole life to their faith.
It's immense.
Okay, let's unpack this a bit because I'm trying to picture how this actually works mechanically in the brain. How do we remember this? It almost feels like having a broken smoke alarm in your house.
Oh, I like that.
Right, so the obsession is the alarm screaming at top volume that there's a deadly fire, even though you just burnt a single piece of toast.
That is a really solid starting point for the mechanism. The brain's threat detection center is just completely misfiring. But if we want to be really accurate to the neurobiology here, let's take your analogy a step further.
Okay, do it.
So, if the obsession is the blaring smoke alarm, the compulsion, so the hand washing, the counting, the praying, is you spraying a fire extinguisher.
Right.
But imagine that fire extinguisher is actually filled with gasoline.
Wait, gasoline?
Yes, because here is the trap of OCD. The compulsion gives you a temporary, fleeting sense of relief. You feel like you did something to prevent the fire. But neurologically, every time you perform the compulsion, you are validating the broken alarm.
Oh.
Yeah, you're teaching your brain, yes, that intrusive thought was a legitimate, deadly threat, and my hand washing just saved our lives. So you are literally pouring gasoline on the underlying anxiety.
Wow, so the next time the thought pops up, the alarm is even louder.
Yeah.
And you're reaching for the extinguisher even faster.
Exactly. It's this devastating cycle of negative reinforcement.
That makes total sense. You aren't fixing the alarm, you're just feeding the mechanism.
Yeah.
And I feel like that connects perfectly to a major cognitive bias we need to talk about from the chapter, which explains why these thoughts feel so dangerous in the first place. It's called a thought-action fusion.
Yes, this is perhaps the most crucial concept to grasp if you want to understand the moral agony of OCD. People with OCD often suffer from this cognitive fusion, where their brain fundamentally blurs the line between imagination and reality.
Right.
They believe two distinct things. First, they believe that simply thinking about a bad event makes it statistically more likely to happen in the real world.
Okay, so like if I think about my mom getting in a car crash, I have somehow magically increased the odds of her actually getting in a car crash.
Exactly. You feel responsible. And second, on a profound moral level, they believe that thinking or repugnant thought is morally equivalent to actually committing the forbidden act.
Oh, man.
Yeah, so if someone has an intrusive, unbidden thought about harming a child, thought-action fusion tells them you are just as evil as someone who actually harms a child.
Which is an incredibly heavy moral burden to carry around. I mean, no wonder the compulsions are so desperate. If you genuinely believe you are morally identical to a murderer just because a random neural misfire popped an image into your head, of course you are going to wash your hands until they bleed to try and cleanse that anxiety.
Precisely. The brain essentially weaponizes your own morality against you.
Okay, so we just looked at how a broken internal smoke alarm drives people into these invisible, repetitive mental loops.
Huh.
But what happens when that broken mechanism is tied to a feeling of joy rather than a feeling of fear?
That is a great transition.
Right, because that's where the brain crosses the line into a totally different physical manifestation, which is hoarding disorder.
And this is a massive diagnostic shift in the new manual, because for a long time, hoarding was just considered a subtype of OCD.
Right, they just lumped it in.
Yeah, but it was officially separated into its own distinct condition because the underlying mechanism, like the why of the disorder, is fundamentally different.
Yeah, and it makes total sense when you look at the person's actual experience. With OCD, the patient is deeply distressed by their obsessions. They know the smoke alarm is broken. They hate it. But hoarders, they're actually excited by acquiring objects. They form these deep, profound emotional attachments to physical items.
And the neural activity in the brain tells the whole story here. When someone with OCD engages in a compulsion, it's about anxiety relief. But when a hoarder acquires a new possession, even something most of us would consider literal garbage, it triggers the brain's dopamine reward pathway.
They get a neurochemical hit of joy.
Exactly, joy and satisfaction.
And the physical consequences of that dopamine loop are just jaw-dropping. Did you read the case in the text about the 70-year-old man in Burnaby, British Columbia?
Oh my goodness, yes. The chainsaw one.
Yes. So a friend reported him missing, and when firefighters arrived at his house to check on him, they literally had to use chainsaws to cut through the front hallway.
Just to get inside the house.
Just to get through the door. The debris was stacked floor to ceiling in every single room. He had been trapped under a collapsed pile of his own possessions for days.
And here is where we see the profound lack of insight that often accompanies the disorder. Because after he was rescued, city staff noted that this man genuinely believed his property was beautifully arranged for his, quote, best personal health and safety.
Which is wild.
The cognitive distortion was just so strong he couldn't see that he was living in a lethal trap. I mean, he would have died if the firefighters hadn't cut him out.
But I have to push back a little here because I think a lot of people listening might wonder about their own habits. Like, where is the line between a passionate collector and a hoarder? Because my uncle has a garage entirely full of vintage license plates. He loves them. Does he have a disorder?
That is the exact question clinicians have to answer to avoid over-pathologizing normal human behavior. The key difference lies in the prefrontal cortex. That's the part of the brain responsible for categorization and decision-making.
Okay.
Collectors curate. They have a narrow range of items, they categorize them, they display them, their prefrontal cortex is functioning perfectly. Hoarders, on the other hand, experience a complete breakdown in that categorization center.
So they can't sort things.
Right. They lack selectivity, they accumulate without distinction. So junk mail, old food containers, and broken appliances all carry the exact same emotional weight as a priceless family heirloom.
Okay, I have a memory trick for this. It's like the difference between running a museum and living in a landfill.
Oh, I like that. Break that down.
So a collector runs a museum. They curate, they organize, and they invite people in to appreciate it with them. A hoarder is trapped in a landfill. It's indiscriminate accumulation, and instead of inviting people in, the physical mass of the objects literally isolates them from the rest of the world.
That's a highly accurate way to frame it for the exam.
Yeah.
And the crucial clinical benchmark there is life impairment. Collectors don't lose the ability to use their living spaces. Hoarders lose the fundamental utility of their homes.
Right.
Like you can't sleep in the bed because it's covered in newspapers. You can't cook in the kitchen because the stove is buried under broken electronics.
Exactly. Okay, so hoarding is an obsession with the external physical environment. But what happens when that repetitive loop turns inward? Not on your abstract thoughts like OCD, but on your actual physical body.
That brings us to the next section, body dysmorphic disorder, or BDD. With BDD, the person is entirely preoccupied with an imagined or highly exaggerated physical defect. Usually it's focused on the face, like the skin, the hair, the symmetry of the nose, but it can anchor onto literally any body part.
And the 10 makes a huge point of this. We really need to emphasize loudly that this is not vanity.
No, not at all.
Vanity is wanting to look better than everyone else. BDD is a torturous loop of feeling monstrous and deformed.
It really is. And it's incredible how prevalent it is, even among people whose job is literally to be looked at. Like actor Reed Ewing from Modern Family has been very vocal about his BDD. He talked about undergoing numerous plastic surgeries starting at age 19 to fix perceived flaws. Surgeries he deeply regrets now.
Yeah, and Uma Thurman has also revealed she suffers from it. But my pushback here as we're studying this new category is, well, why is this grouped with OCD? Isn't being terrified of how you look and avoiding social situations just extreme social anxiety?
It looks like social anxiety on the surface for sure, but the mechanics are totally different. The defining criteria for an OCRD is the presence of repetitive behaviors. Oh, okay.
People with BDD are locked into compulsions. Excessive grooming, spending 6 hours a day checking mirrors, or the constant agonizing mental comparing of their appearance to every single person they see.
So they're performing a ritual.
Exactly. Just like the hand washing in OCD, the mirror checking in BDD is a desperate attempt to regulate the severe anxiety caused by the obsession.
Okay, so if I'm trying to visualize this for my notes, it's like a funhouse mirror. When you or I look in a mirror, we see our reflection. But BDD acts as a severe cognitive filter. When someone with BDD looks in the mirror, they don't see what the rest of the world sees. They are looking into a funhouse mirror that grotesquely distorts a specific feature.
Let's actually unpack the visual processing glitch behind that funhouse mirror, because neurologically, that is exactly what is happening.
Really?
Yeah. When a neurotypical brain looks at a face, it uses what we call holistic processing. It takes in the whole picture at once. But functional MRI scans show that someone with BDD has a hyperfocus on detail processing.
Oh, interesting. Their brain literally cannot see the forest for the trees. It zeroes in on a single pore or a slight asymmetry in the jawline and magnifies it until that single detail completely eclipses the entire face.
Wow. So their brain absolutely insists that the distorted reflection is the objective reality. The text noted that up to a third of patients have such poor insight into their condition that it borders on delusional. They literally cannot be convinced they look normal.
Which perfectly explains why plastic surgery never cures the disorder and honestly often makes it worse.
Right, because the surgeon is operating on the physical tissue of the body,
Hmm.
but the defect only exists in the visual processing center of the mind.
Exactly. You fix the nose, and the brain's detail processing glitch instantly finds a new flaw on the chin to obsess over. And the distress is so severe that BDD carries an exceptionally high risk of suicidality.
That is just harrowing. It really underscores how this isn't just insecurity, it's a fundamental misfire in perception. Now, taking this bodily focus one step further, we move from just perceiving the body in BDD to physically altering it. The final section of this new diagnostic category covers body-focused repetitive behaviors, specifically trichotillomania and excoriation.
Right. So trichotillomania is the clinical term for hair pulling disorder. People feel this irresistible mounting urge to pluck out their hair, often from the scalp, but also eyebrows or eyelashes.
Which leads to significant hair loss, which in turn leads to this massive cycle of shame.
Yeah. And excoriation is skin picking disorder, where chronic repetitive picking leads to actual lesions, bleeding, and scarring.
And the social isolation here is huge. You read about people wearing heavy makeup or multiple hats or avoiding haircuts for years because they just can't bear the shame of explaining bald patches or scabs to a stylist.
It's a heavy burden.
But mechanically, how is pulling your eyelashes out similar to OCD? Because it doesn't seem like they're trying to prevent a fire, so to speak.
This is where we see another distinct root cause. Unlike OCD, where the compulsion is driven by a desperate need to reduce obsessional fear like Bernice fearing deadly germs, these body-focused behaviors are frequently driven by something completely different. It's called the frustrated action model.
Okay.
The behavior is often triggered by simple boredom, understimulation, or just general frustration.
Wait, boredom causes someone to pull their hair out?
Yes, because of how the brain seeks regulation. To understand the how, we have to look at a region deep inside the brain called the basal ganglia.
Oh, I remember that from Neuro Intro.
Right, this is your brain's motor control and habit formation center. It's actually the exact same region implicated in Tourette's syndrome, which involves involuntary physical picks. When a person with these disorders feels understimulated or tense, the physical act of pulling a hair or picking the skin releases a tiny hit of tension and sometimes a microdose of dopamine.
So the brain essentially learns, hey, I'm bored and tense, and this physical movement provides a split second of relief. And it just wires that motor movement into a deeply ingrained habit.
Exactly. It bypasses conscious thought entirely. People will often be reading a book or watching TV totally zoned out and realize 10 minutes later that there's a pile of hair on their desk. The basal ganglia just ran the program on autopilot.
So how do you stop a freight train that is wired directly into your motor control center? Like, you can't exactly just tell someone to stop picking. That's like telling someone to stop blinking.
No, you can't. And that is why traditional talk therapy isn't very effective here. The primary psychological treatment is a behavioral rewiring process called habit reversal training.
How does that work?
It starts with hyper-awareness. You have to consciously identify the exact micro-triggers or environments. Like, I realize I always pick my skin when I'm studying for exams, my posture is slumped, and I'm feeling overwhelmed.
Okay, so you identify the trigger. Then what?
Then you develop competing responses. This is the actual physical rewiring part. If you feel the tension mounting and the urge to pull your eyebrows, you immediately perform a different physical action that makes pulling impossible.
Like what?
Like, you grip a rubber stress ball as hard as you can, or you literally sit on your hands for 3 minutes until the wave of the urge passes.
Oh, I like to visualize that. It's a train switch for my notes.
Okay, lay it out.
So the physical tension and the biological urge to pull is a massive freight train barreling down the tracks. You can't just stand in front of the train and use sheer willpower to force it to stop. It will just run you over.
Right.
But by using a competing response, you are pulling a lever and switching the tracks. You redirect that massive kinetic energy away from your face and route it harmlessly into a stress ball.
That is precisely what is happening neurologically. You are acknowledging the biological energy, but you are physically building a brand new neural pathway for the behavioral output. And over time, the basal ganglia learns the new route, and the urge to pick begins to fade.
It's amazing. So look at all the ground we've covered today. Let's kind of connect the dots for the big picture.
Yeah, summarize it for us.
Okay, so whether it is Bernice checking locks and washing hands to stop a fire, or the Burnaby man hoarding old newspapers for a dopamine hit, Or reviewing, obsessively checking a funhouse mirror, or someone pulling their eyelashes out while bored. The unifying thread of this entire new category is the brain getting stuck.
Perfectly said.
It's a repetitive behavior loop utilized to regulate overwhelming internal feelings.
And if we look at why deeply understanding these underlying mechanisms actually matters, like the real so what for you as a listener, it comes down to the danger of misdiagnosis.
Absolutely.
Because misdiagnosing the why leads to prescribing the wrong how to fix it.
Right. Oh, I was reviewing the study by Glazer and colleagues in the text, and it completely blew my mind.
It is a really sobering piece of research.
So they surveyed over 1,000 physicians and gave them a clinical vignette of a patient with OCD. When the patient had classic, widely understood symptoms, like obsessing over hand washing or symmetry, the doctors diagnosed it correctly.
Yeah, the classic presentation.
But when the patient presented with obsessions involving taboo topics, like intrusive thoughts about homosexuality or violent aggression or strict religious violations, over 50% of the physicians misdiagnosed the patient.
Over half of medical professionals missed it
Over half.
because they were blinded by the shocking surface content of the thoughts, and they totally failed to recognize the underlying mechanical loop of obsessive-compulsive disorder.
And the tragedy there is that if you misdiagnose OCD as a psychotic disorder or just generalized anxiety, you prescribe the wrong treatment. You might just give them talk therapy, which doesn't work for OCD. You fail to prescribe exposure and response prevention therapy, which is the gold standard treatment.
Exactly. Exposure and response prevention, or ERP, is where you intentionally trigger the obsession, you force the brain to sit with that blaring smoke alarm, and you actively refuse to let the patient use the fire extinguisher.
Right.
You let the anxiety peak until the brain finally learns there is no actual fire. That is what physically breaks the loop. But if the doctor doesn't recognize the loop in the first place, the patient never gets ERP, and they stay trapped.
It just proves exactly why we have to study the mechanics, the neurobiology, and the cognitive biases, not just the surface-level symptoms.
Absolutely.
All right, we are wrapping up this deep dive into the source material, but I want to leave you with a final lingering thought to chew on before the exam.
Let's hear it.
We talked about how hoarding disorder flew completely under the medical radar for decades. In the 70s and 80s, a clinician wouldn't have even had a diagnostic code for that man trapped in his house in Burnaby. This was considered a quirky, unfortunate habit. It wasn't officially recognized and separated out until very recently.
Which is crazy to think about.
Right. So look around at the world today. Look at how people interact with technology, with their bodies, with their fears. What other human behaviors or silent struggles are flying completely under the radar right now, just waiting for the psychology students of tomorrow to finally recognize the loop, figure out the mechanism, and give it a name?
It really makes you wonder how much we still don't see when we look at the human mind.
Exactly. Keep that in mind next time you see someone or yourself stuck in a repetitive loop. See you at the next study session.